Hello, thank you for your patience. Welcome to the ESIT webinar on Redesigning the Interface in Camden, presented by Richard Cartwright, Head of Performance, and Delyth, Acting Head of Insights, both from Camden CCG. First, we just have a few simple housekeeping points. This session is being recorded and the recording will be available to view on our website shortly. All attendees are muted to avoid background noise during the recording. At the end of the presentation, there will be the opportunity to ask questions. If you have a question, please use the raise your hand option in the panel on the right-hand side of your screen. Alternatively, you can write your question in the question section on the panel. During the Q&A sections, we will unmute you to ask your question in person. Thank you, and I'll now hand you over to Delyth and Richard. Thank you.
Thank you very much. Thank you. So I'm Richard Cartwright. We're going to be talking to you on this webinar today about the multidisciplinary team that we have at Camden CCG and a metric that we've developed at the CCG on spending the amount of time that people spend at home. Just to give you a little bit of background, this metric has been developed by our in-house Sustainable Insights team. It's an analytics team that provides reports and tools over and above the analytical support that we get from our CSU, which mostly provides transactional data support. The Insights team at the CCG provides more of the support around transformational data and supporting our programs. So as I say, we're going to be talking mostly about the MDT and the spending more time at home metric, but first I'll hand you over to Del to give you a little bit of background about our frailty program and the demographics in Camden.
Hi, welcome to the webinar. I'll go straight in to show this very complex slide. This is a little bit around why we needed to act in Camden. This is a representation of an intergenerational poor health within a family. On the top line we have Muriel, not the real name, her daughter Janine and her son Joshua. These three were very complex patients and more needs. And over the time, all their needs were costing thousands and thousands of pounds per year to the NHS and to Camden specifically. But the outcomes for the patients weren't that great either. There was potential to improve their quality of life. So why outcomes? We're very good in the NHS at measuring all the transactional information. We look at our contracts, how much have we bought and how much are we acting towards it. Hospitals are performance monitored mainly on clinical indicators such as infection and mortality rates, but these indicators don't provide the full picture to us. It doesn't tell us what matters the most and what the outcomes for the patients were, how was their experience of the healthcare. So we have looked very much at the Michael Porter work from Harvard. And the top point here, the fundamental goal of healthcare is to increase value, and we must define value as the outcome that matters to patients divided by the cost of achieving those outcomes. So it's not always about low cost, it's about achieving best value as a whole of the patient outcome as well as the value for money. So as a result of this, Camden CCG is embarked on a process of outcome-based commissioning. We've already got a value-based contract in place for diabetes, and we're in the process of looking into SMI, serious mental illness, and the frail elderly IPUs. So value-based contracts for these two. So we have based a lot of the work that we've done around Michael Porter's principles. Although the US system is very different, the profits incentivizes the healthcare organisations to produce better outcomes for patients through being embroiled into the contract. And they look at three different tiers of outcomes: the longer term survival, the tier 2 time to recovery, and then the sustainability of health. So when we wanted to replicate this in Camden, we based it on these outcome measure hierarchies. And the first step was to work with our patients. So this was very member-led by our GPs, and they were crucial to the process, but it was the patients that were central. And we held a ream of different patient engagement meetings and asked the patients what was important to them. So very different things came out, but one of the main things was the time spent at home. This is the example of the outcome hierarchy that we developed for the frail elderly. So it's a little unclear on here, but it's very much looking at the same principles of the tier 1, tier 2, tier 3 as for Michael Porter's hierarchies. And very much within tier 2 you see the number of days spent at home. Oh, my laptop's just frozen. So part of these, it's all well and good having the hierarchies in place. We needed to understand how we were able to bring these hierarchies to life. There are a lot of outcomes that are proposed to measure that actually are immeasurable. So we needed to sit down with each of these outcomes that had been defined to understand where the data would come, whether it's a data source that would need to be set up, the frequency, the timescale, and the granularity of data. Behind this, we could not have done this in Camden without our accredited safe haven. So due to all the IG issues that were put in place when we came to being as a CCGM Section 251, it made it very difficult to monitor on a patient level. Having the ASH status allowed us to be able to link data sets and follow through by patients, albeit for the analysts all on a pseudonymized basis, but the ASH in the background was enabling the linking of the data sets. So I will hand over to Richard.
Thanks, Del. So when we were looking at outcomes in these programs, we thought about what success would look like. For a lot of the outcome measures, they were quite long-term outcome measures. So when you're looking at things like mortality rates and things like that, because of the way that the data is collected and also the long-term nature of them, you're not going to see success in those things straight away. What we decided we needed to look at was intermediate outcomes, which we called progress markers. For example, with diabetes, one of the progress markers was HbA1c levels, monitoring those which would lead to a reduction in emergency admissions eventually for things like ketoacidosis. Frailty program, it was looking at things like whether the people on the frailty register have a care plan, and that would eventually lead to a long-term outcome measure of fewer A&E attendances and fewer emergency admissions. What we did is for frailty, we've identified different levels of frailty in the population. So as a CCG, we've got quite a young population, but we do have a significant minority of older people, and this segment of our population, the older people, is expected to grow significantly in the next few years. So we broke our population down into different segments. So looking at the whole of the over 65 population, the people on the frailty registers in our practice frailty registers, and the people who've been referred to our multidisciplinary team. What we're going to focus on in the next few slides is the multidisciplinary team, or the MDT cohort. So I'll just give you a bit of background about our MDT. It's a team made up of a whole host of healthcare professionals and other people. So we've got physios, acute geriatricians, GPs, people from social care, local authority. They come together and they discuss patients and their needs on a weekly basis. So when people are referred to this team, every aspect of their healthcare is discussed. So, for example, if somebody's fallen over and fractured their hip in their home, it won't just be the physical aspect of their healthcare that's discussed. It will be things like somebody going round to their house and taping up the bit of carpet that they've fallen over. So every aspect of their care is catered for, so that people are ready to be discharged from hospital as soon as possible, and everything's in place to get them better outcomes. So the key enablers for monitoring these outcomes, the most important one was gaining patient consent to allow the measurement of this metric on spending more time at home. Patient consent to look at their data and to measure this is gained at the point of entry into the MDT system. So when these patients are referred to the MDT, consent is granted at that point. What this allows is data sharing between organisations, not only so that the patient can be discussed at the actual MDT meetings, but importantly it allows us to look at SUS data to measure the impact that the MDT is having. So the MDT has been going for around 3 years. We've had over 400, well over 400 of our most complex patients in Camden referred to the MDT. This chart here that you can see represents actually each one of those patients. So each pair of vertical dots on this chart, the red and the green dots, represents one patient. What it does, it shows the amount of time they were spending at home before referral to the MDT and after their referral to the MDT. Basically, what you can see is that 74% of these patients spent the same amount of time or more time at home after they were referred to the MDT than they did before, which is a fantastic result given that they are actually the most complex patients with complex needs, and you would expect them to be deteriorating in terms of their the amount of time that they're spending in hospital. So to have 3/4 of them spending the same amount or more time at home is a great result. So the data split down to a pod level. What we can see here is the cohort's use of A&E before and after referral to the MDT. What we found is that 27% reduction in A&E attendances after people referred to the MDT. So these people were going significantly less to A&E after MDT case management than they were before, which yeah, at a time when performance standards like the 4-hour A&E target are really coming under pressure, that's a great result, not just for us but for our providers as well. This is where it gets really interesting when we're looking at emergency admissions. So at first, when we first started looking at this data, we found that emergency admissions fell significantly. The more that this cohort has grown and the more people that have been referred to the MDT, what we're finding is that emergency admissions have actually increased slightly after referral to the MDT. The assumption is that actually we were going after what we would call the low-hanging fruit at the start of it. So it really was the patients with the most complex needs. So it's not really a surprise that we were able to make a significant reduction in their use of emergency admissions and the time that they spent in hospital. But the really interesting thing is this on this next slide. Despite the increase in emergency admissions, emergency bed days have fallen. and most significantly, so have costs. So when people are being admitted, when this cohort are being admitted to hospital, we're finding that they're being admitted for lower cost things and they're being discharged earlier. Probably because everything is in place at home and they're actually ready to be discharged. So that's fantastic news. Here we can see the benefit to the whole system, so the system-wide benefits that we've been able to measure the impact of the MDT. So the main thing for us is the outcome for the patient, so the one at the top. The benefit to the patient is that they're spending more time at home. And as I said, 74% of patients spent the same amount or more time at home following MDT case management. The second thing is the reinvestment opportunity that we have in terms of our secondary care savings. Over the course of the MDT being running, we've saved over £500,000 in secondary care savings. Now, this money is money that we can reinvest into other areas such as primary care and community care, which really will be keeping this cohort of patients out of hospital, and if they are admitted to hospital, allowing them to be sent home earlier, which is fantastic. The third thing, which is very difficult in a lot of things when you're measuring these sorts of outcomes and the impact of these things, the benefit to the provider. I touched on the benefit of the A&E, the reduction in A&E attendances, and the benefit that will bring to providers in terms of meeting the 4-hour A&E constitutional standard. The other benefit that it will bring, obviously, is with fewer emergency bed days, it frees up capacity in our providers. This is a particular benefit where providers are struggling with RTT and with A&E targets. To be able to free up bed capacity is a really, really positive thing that we can show an impact of for the system. So for these patients to be spending less time in hospital, it's not just good for them, it's good for the CCG in terms of money, and it's good for our providers in terms of freeing up capacity. So that's our overview of the MDT and this measuring time spent at home metric. I'd like to open it up now to see if there are any questions.
Thank you, Richard. Thank you, Delyth. As Richard said, if anybody's got any questions, feel free to raise your hand in that option in the panel on the right-hand side of your screen, or alternatively, you can write your question in the question section, and I can read that out to Richard and Delyth. Or if you raise your hand, like I say, I can unmute you to ask your question in person. So it looks like we've got a question from a gentleman called Chris Wood from Coventry Rugby CCG. I'll just unmute Chris. Hello, Chris. Can you hear us?
Yes, I can. Yes. Can you hear me?
Oh, yes, lovely and clear.
Hi, Chris.
Hiya. It was just a question. You talked about the relative savings that you pulled out. I just wondered what investment you'd put in at the start and how you funded the MDTs.
So the MDT was funded as as one of our transformation programs. So that was funding that the CCG had got through a business case and then funding as part of our transformation program. But obviously, the secondary care savings are a reinvestment opportunity that we can put towards more things like that, and to funding the MDT itself.
Sure. Okay.
Okay, lovely. Thank you, Chris. Looks like we've got another question from Michael Dimov. I'll just unmute you, Michael. Oh, looks like Michael's self-muted. Can you unmute yourself, Michael, to ask your question?
Yes, unmuted. Yes.
Oh, lovely.
Yes. Hello. Hello. Thank you very much. I'm General Manager from London Northwest Healthcare NHS Trust. Thank you for most interesting presentation. I had a question about the reported 27% reduction in A&E admissions after MDT case management, which you described. Can you explain over what period of time was that sustained or observed?
So that refers to our whole MDT cohort. I think the 27% was A&E attendances.
A&E attendance, yes.
Yeah, so the way that we monitor this is it's the 6 months before and the 6 months after each patient has been referred. So it's monitored on an individual basis based on their data referral to the MDT. But that 27% reduction is referring to the whole of the cohort. So that's ever since
averaging. Yeah. Okay, thank you.
Okay, thank you very much, Michael, for your question. We haven't got any other questions at the moment. Just give it a minute if anybody would like to type one in, or again raise your hand and I can unmute you. As you can see on the screen, Richard's got his email address, so if anybody would like to, if they think of anything after the webinar's finished, feel free to email Richard his address, or you could also email the ESIP info box, and that's the email address is esipinfo@nhselect.org.uk. So I think Chris has got his hand up again. Hello, Chris.
Oh yeah, it was just a question about the work streams you're currently involved in. So you talk about frailty. Is there any plans to do this multidisciplinary team type of setup for any other areas? Is this something that you can roll out sort of across the board, or do you think you've found all those different cohorts of patients?
So it's definitely something we're looking at, and it'll be different models for different cohorts of patients. So other work we're looking at is the population health management in my team. So it's looking at the impact of multiple diagnoses on patients. So the MDT really lends itself to the frailty because of the complexities of the social care need, the district nursing, as well as the consultants from hospital. So we would be looking at some sort of MDT approach for extending the frailty programme. Also the serious mental illness, there's the cross-working, so might not be the same MDT, but it would be along the same principles, definitely working across practices and the mental health providers. Does that help at all?
Yeah, and how do the patients get referred into the MDT? Is it through GPs or discharges, or is there a raft of ways in?
There are a few different ways in, but predominantly via the GP would be the referral method into the current MDT. But correct me if I'm wrong, Richard, but I think the MDT team also have access to the wards in the hospitals too. So
yes, it is actually something we monitor in our regular reporting to our frailty team, the sources of referrals to the MDT. As Del said, it is predominantly GPs, but our community partners and acute geriatricians also refer into the MDT.
Okay. All right, thank you.
Okay, lovely. Thank you, Chris. Doesn't look like there are any other questions at the moment. Is there anything else? Oh, looks like somebody's just popped one in. The question's from Ita Johnston, and the question is, how much does it cost?
Off the top of my head, I wouldn't be able to answer that, unfortunately. It's as far as I'm aware, it's more than covered by the savings that we are able to take out of secondary care. it's not a loss-making program. If that's the sort of the gist of it. It is covered by the secondary care savings. But obviously, one of the key things that we were looking at in terms of this was patient outcomes as well. So the benefit to the patient actually spending more time at home and being healthier is quite a key thing as well.
Okay, ITA's also typed in, have you done an evaluation, and can you share the evaluation?
We have various reporting that we've done, so there are some of our regular routine reports. It hasn't been a full external evaluation, but we do have some statistics we can share with her if she would like to email.
Okay, that's lovely, thank you. It doesn't look like there are any other questions at the moment. Oh, ITA's put great, thank you. Is there anything else you'd like to add, Richard or Delyth, before we finish up?
Not particularly. As you said, we're more than happy to take more questions and queries and things out afterwards, contacting myself or Del via email. It's a bit of an abstract concept, this one, the measuring time spent at home, because you're actually trying to grab hold of something that hasn't happened. So in terms of the actual measurement of it, as I say, it's a bit of an abstract concept, and people often struggle to get their heads around how to actually monitor that. So, as I say, more than happy to share our methodologies and to help people who'd be interested in doing something similar.
Okay, that's lovely, thank you. I think this brings the webinar to a close. Just to say thank you to Richard and Delyth for providing us with this presentation today. And also just a quick reminder that the recording of the webinar will be available to view shortly on the ESIP website. So just to say goodbye from all of us, and thank you for joining us today. Thank you. Goodbye.
Bye.
Bye.